So hi, everyone. To echo what Phil said, thank you so much for joining us in this week. Just a little bit in terms of like the flow of things for tonight, we'd like to save questions for after both speakers have shared their presentations with us. But if anything, burning pops into your mind, you don't want to forget, feel free to put them in the chat and we can address them first after the presentations are done. So without further ado, I'm happy to introduce our speakers in the order that they'll be presenting. Our first speaker, Dr. Lunagariya, is an Associate Program Director of Neurology Residency at the University of Central Florida. He also serves as Chair of Quality and Patient Safety Committee. He is a stroke expert with dual training and board certification in neurology and vascular neurology. He received stroke and vascular neurology training at the University of California, San Diego, under the tutelage of world-renowned stroke expert Dr. Justin Divin. Dr. Lunagariya is active in stroke research and is a recipient of the prestigious National Institute of Health Stroke Net Funding Award. He is frequently invited to various national and international conferences to share his expertise. He also serves on the editorial board and as a reviewer of multiple neurology and stroke journals. His interests include physician leadership, healthcare disparities, and stroke systems of care. Our second speaker, Dr. Etienne, is an alumnus of New York Medical College, where he currently serves as Associate Professor of Neurology and Medicine, Vice Chancellor for Diversity and Inclusion, and Associate Dean for Student Affairs. He is board certified in neurology, epilepsy, clinical neurophysiology, brain injury medicine, and public health. Dr. Etienne is a visiting scholar at the National Center for Bioethics and Research and Healthcare at Tuskegee University, and is the Director of Epilepsy and EEG Laboratory at Good Samaritan Regional Medical Center, part of the Westchester Medical Center Health Network. Dr. Etienne has numerous book chapters and has several publications in peer-reviewed journals. He is also currently serving as the president of the New York State Neurological Society. So whenever you're ready, Dr. Lunagariya, you can go ahead and start. I'm sorry, I think you're muted.
Okay, can you hear me now?
Yep.
Perfect. I'm just like sharing a slide, but it's like just a couple of pictures here and there. So thank you for having me here, guys. Let me share my slide properly. Okay, can you see it properly? Like, can you see the PowerPoint or?
Yeah, we can see the PowerPoint. You're on.
Very good. So I don't have any grant, no pharma device funding yet. A part of this work was done using StrokeNet grant in past, but like right now I'm not a recipient. I don't have any conflict of interest. Just to ask you guys, can you see this map? Like, what does this map show? It shows that something is like very disproportionate in part of USA more than the other part. Whatever is dark is like more affected. Whatever is light is less affected. I mean, or purple, like darker purple is more affected. We'll come back to the slide in the end, I would say. Would anyone like to make any guesses?
Is this in reference to the stroke belt in the southeastern United States?
Yeah, that's true. I mean, you got it right. So pretty much like why I'm talking about stroke. It's like one of the leading cause of death in USA. Like pretty much number 5, and we are not proud to say that it's number 5. Every 40 seconds, someone has a stroke. Every 4 minutes, someone dies of a stroke. Directly, it burdens like 34 billion, which doesn't sound a lot like in terms of money if you see overall budget, but there is a lot of indirect costs associated with it, and that's a very heavy cost to the society and the country. There has been numerous attempts in last couple of years, last decade or so, like numerous guidelines, numerous certification, numerous like requisites going on in order to address like this issue. But we do not know for sure how much of that is like effective or like how much of impact is it making right now. So the question is like, where do we stand in terms of stroke care? How disparate how disparity we have, or how much equal we are like across the country. So there was a data which was like mined a couple of years ago, like it almost included 9 million population. for like span of more than a decade, and it just shows that with every passing year, number of stroke patients keep on increasing in USA. If you see the regional differences, like the red color is like signifying south, you can like see that like the stroke is far more affecting people in south or like south mid, I would say, like compared to other parts of country, compared to Midwest or West or Northeast. Partially it might be because of higher population there, but like it's not just completely because of like more population, because as we know, like pretty much like even Northeast has a higher population, West has a higher population, but somehow stroke is more affected in South more than the other. Fortunately, we have like more than 9 times increase in use of TPA, which is great. That use has been like more across the country, like it's not just in one part or the other part. So that's like something which is really remarkable. Strength, the length of stay is like getting down and down, which means like patients are getting better care these days than what they used to get earlier. Length of stay is still like disproportionate, but like it's slightly more in the Northeast compared to like other parts of a country. Cost of admission is going down and down with there was an upward trend in the mid 2000s, but now it's getting down, which is good. Even if like South has like higher number of stroke, it's still like cheaper to like get stroke treated there compared to other parts of country, which might be partially because of like cost of living. And coming back to the same map again. So I think a few of you guys were able to pick it up. The map is like by CDC. It shows that like how many people of age greater than 35 are dying from stroke. And there is a rate per 100,000 population. So this is not just like because there are more people living there, we have more rate. This is like per 100,000 population. And as you can see, like people in the stroke belt are disproportionately affected because of like stroke, no matter how you slice it. This is like a stroke in a white non-Hispanic population. Same, I would say same like a kind of distribution. If you look at the Afro-American population, Black population, it's even more significantly like affected in South compared to other parts of a country. And it also includes Florida, where I am from, or where I'm living right now. The Hispanic population like Florida, Texas, and Western US are affected more. Again, these are rate per 100,000 population. Only difference is that like they did not slice the population based on their like demographics. So it's just 100,000 people, no matter what race, what color they are from. Similar is the situation if you like see adults more than 65 years of age. Same for white, Black, and Hispanic. And this is a hospitalization rate. So as you see, like the darker part in the stroke belt start getting lighter. In other words, what it signifies is that even if more people dies from stroke, somehow not like that much people get hospitalized because of stroke. And that does mean a lot. Means the people are getting stroke, but for some reason they're not getting hospitalized for the stroke. And if you see like some densely populated parts in the Northeast, you will see like even more people being hospitalized than the other parts of country. This is for white, Black, and as you can see, like more people from stroke get hospitalized somewhere in Midwest or somewhere like around the Rust Belt, rather than somewhere where there is more stroke for some reason. And similar for Hispanic population, even if more of them get stroke in like different parts of country, more of them are hospitalized in Northeast, maybe some in Florida, maybe some in like metro cities of Texas. But it's different than like number of people having stroke there. This is the same chart in a different like formulation. As you can see, like these are number of people dying from stroke who are age greater than 35. And as you can see, like it's widely disproportionate. Like it's more in the Northern Marine Island, more in Guam, more in like certain states of US mainland compared to the other states. So we know that like where we stand in the care of stroke, but anyone can like make a estimate that why do we have such a large disproportionate outcomes? So long story short, I mean, stroke is a pretty complex and a highly time sensitive disorder. It matters at how quickly it gets diagnosed and how fast one receives the care. If you see like another contributor of mortality like cancer or some other condition, stroke is different in a way that it needs to be treated right then and there. A patient cannot go to like a very specialized hospital 500 miles away most of the time. It needs to be treated where it happens most of the time. And on top of that, like there are very few neurologists in this country, and even very few of them are like stroke certified, stroke trained neurologists. In other words, if you like do the demographics, there is one stroke doctor per more than 180,000 population. If you see another similar condition, like for example, heart or cardiology, you will have like almost like one cardiologist per 10,000 population. So there is a wide disparity among the stroke doctors and neurologists. And as you can imagine, like most of them would be living even in a bigger city. And that's why like people in bigger city would be hospitalized more. They will be getting better care compared to those who are like living in suburbs or somewhere like deep in the country. So what are we doing for that? A couple of things have been done like from different society. This is one of the striking part. It's a FAST Act, which stands for Furthering Access to Stroke Telemedicine. That was one of the initiative by American Academy of Neurology. We have been invited every year to go to DC. Of course, not this year, but the last year was still was going. Neurologists from different states are invited to go to DC and meet the senators and congressmen. It's called Neurology on Hill. We proposed different bills, and FAST Act was one of the bills which was proposed and which was like successfully approved. So what does it do is that like back in the days, Medicare was only covering the telestroke if patient was treated in rural hospital, but not in the urban and suburban hospital. And the definition of rural was very sporadic for different location. But with the FAST Act, now they are like promoting or reimbursing telestroke services, even if it is in rural location. In other words, like even if patient gets a stroke, like maybe 500 miles away from me, I can still see the patient and he'll still treat the patient without wasting so much time. Another policy making is done by NINDS, National Institute of Neurological Disorder and Stroke. This is their budget for all the healthcare disparity from NIH. As you can see, like it's in $3,000 million. And like it keeps on increasing every year except like 2019 and onwards. It sounds like a high budget, but not a lot of it is like spared for the stroke care. But there are a couple of like grants for the stroke. Regards is one of that. Northern Manhattan Study is one of that. Brain Attack is one of that. But most of these grants are at bigger university setting, mostly in the bigger locations. Then there are a couple of federal programs as well. Stroke Disparity Program, Alaska Native Stroke Registry Program, Greater Cincinnati Program, and different programs in the bigger cities, bigger university settings. American Heart Association, American Stroke Association realized this thing very early on, and they are going more deeper than just like covering the bigger cities. They have various programs like Together to End Stroke, Strike Out Stroke, Spot a Stroke, different initiative to increase the awareness among the population and try to bring more and more patients to a hospital before damage happens. And there has been some success with that, but again, like going deeper is always the challenge. So in conclusion, like US stroke care is very disproportional, especially stroke belt is very heavily disproportionately affected. Most of poor people, like a lot of colored people live there and they are very disproportionately affected there. We have been making some inroads in like terms of TPA utilization across the US, whether it's South or North or Northeast or Midwest, but it's still like more like used mostly in the Western region. Cost is like significantly like higher in one part of a country than the other part. Maybe it's related just to like a cost of living. And this is what we have so far, and we are trying our best. This is my mentor, Dr. Justin Zivin. He passed away in 2020 after like we were trained, and staying to him for like all this wonderful teaching he gave to us. And these are a couple of references, and I think it's a time for discussion. Feel free to like shoot any question.
Yeah, so if anyone has any questions that they'd like to put in for Dr. Lunagariya right now in the chat, feel free to do so. But if not, we can just move on to Dr. Etienne's portion, and then we can have a larger discussion at the end of it, just kind of addressing all the questions at once.
So one of my questions is, telestroke seems to be a way to bridge the gap between these disparities within stroke care. What are some of the barriers to telemedicine currently?
So the biggest barrier I can see is that like it's a legislative barrier. Like for example, if I want to like, I'm right now located in Orlando, Florida. When I was in like San Diego, California for my training as a stroke, even as a fellow, I used to like cover 5 different hospitals. But keep in mind, one has to be certified and credentialed for the hospital where patient is located. So for example, if you are sitting in Manhattan and like a patient is in New Jersey, I can be corrected. I do not exactly know the regulation in times of like in the northeastern, especially with the COVID, but like if you take out the COVID, like you have to be licensed like in the state where patient is located. Another thing is the technology. Not all the hospitals are equipped with that. Another thing is just like sheer volume of stroke patient. I mean, a lot of times like stroke neurologists are not available because they are far and few out there. But even being another specialty neurology, there's so few of us that like they won't be available to cover all the hospital 24/7. And imagine waking up in like middle of night at 1 o'clock just to see a patient who is a stroke mimic. It's always a challenging thing. So access is a very limited thing, and it purely comes from the bottleneck, the way that take for example like something which is of similar acuity, like for example heart attack or MI, myocardial infarction, is taken care by cardiologists who are trained from internal medicine, and just count the number of internal medicine residency sport we have in this country compared to neurology sport and compared to stroke fellowship sport. Every year like we meet for stroke conference and we know all the faces pretty much like good or not so good, because like there are barely like 40 to 50 good fellowship in this country training stroke doctors, and most of the fellowship have 1 or 2 sports. Only few of them have 3 or 4 sports. So there are far and few of us out there.
Does anybody have any questions that they want to ask right now? If not, Dr. Etienne, feel free to go ahead whenever you're ready.
Okay. Let's see here. So I'm going to share tray. Do you see my first slide?
Yes, we can.
We can.
Okay. Okay. All right. So good evening, everyone. Thank you for joining us this evening as we address issues related to NeuroEquity. I did want to extend my congratulations to the team of students who have organized this week's event. Definitely it's been a Herculean effort on their part. Thanks particularly to Phil and Stella who have worked to prepare this evening's discussion. Well, I'll be talking about traumatic brain injury, health disparities in traumatic brain injury, and then also specifically looking at, what impact can legislation have on eliminating health disparities or health inequities. I have no conflicts of interest. I'll start with this slide that you probably are familiar with. That I got it off their social media site. the mission statement for the NeuroEquity Coalition to advance innovative, patient-centered initiatives targeted at addressing systemic health disparities in neurology through actionable and transformative programs. So we'll start with a little bit of background about TBI. It's a critical global public health concern that is both widespread and costly. 69 million new cases occur annually at a global cost of $400 billion US. The incidence of TBI is rising with disproportionate increases in low and middle income countries. And it is the leading cause of death and disability in people age 1 to 44. In the United States specifically, 3.5 million people sustain a TBI each year. In 2014, an estimated 2.87 million TBI-related emergency department visits, hospitalizations, and deaths. 1/3 of all injury-related deaths are TBI-related, and an estimated 4.6 million cases do occur annually in the United States and Canada. And furthermore, up to 5.3 million people in the US live with the sequelae of TBI. So you have a TBI, you're going to be many people end up living with it with the effects for a long period of time, even when your doctor or provider has called it a mild TBI. The estimated cost per year is upwards of $73 billion, and TBI carries an annual cost per person, a lifetime cost per person of $396,000. So it's very, very costly to our society. So TBI, it's caused by a bump, blow, or jolt to the head, or a penetrating head injury that disrupts the normal function of the brain. The severity of TBI can range from mild. When there are mild TBIs, we often refer to these as concussions, and they could also be severe. And severe TBIs typically may have extended periods of unconsciousness, or they may have bleeding in the brain, skull fracture, and other long-term issues. The most TBIs that occur in the United States are mild, and again, they're commonly called concussions. The causes of TBI, these are the leading causes. 28% of them are from falls, but in the elderly, that is the most common cause of the TBI is going to be the fall. The motor vehicle crash is number 2. However, the motor vehicle crashes are the number 1 cause of death related to traumatic brain injury. People could be hit by or colliding with an object, 19%. I know I have patients, things fall from the ceiling, cabinets or what have you. Assaults, 11% of TBIs. The violence from suicidal behavior or assaults using firearms are the leading cause of TBI-related death. And then there's lots of other causes of TBI. So what do I have this military guy here? Obviously, one is because I am in the military, but over the last couple of decades, we have come to better understand traumatic brain injury, largely because of the wars in Iraq and Afghanistan, but also because of the increased attention given to TBI in professional sports, specifically the NFL. You see some statistics here. More than 400,000 U.S. service members were diagnosed with a TBI between 2000 and 2019. Approximately 80% of TBIs among this group occurred from injuries, such as from a motor vehicle crash when the person was actually not deployed. Studies suggest that service members and veterans who have sustained a TBI may have ongoing symptoms, experience co-occurring health conditions such as post-traumatic stress disorder and depression, difficulty accessing health care. So service members are themselves actually at a disparate, health disparity. And they report thinking about or planning suicide attempts. One of the interesting things about the military is because of the advances with Kevlar and the body armor, a lot less people are dying on the battlefield from these injuries to the body, but a lot of times they end up now having the head trauma. So that's why the signature wound of the Operation Iraqi Freedom and Enduring Freedom has been traumatic brain injury. The common symptoms of TBI and the sequelae of TBI, headaches, one of the most common things I see in patients who have TBI. dizziness, cognitive deficits. There's a wide range of cognitive deficits, but more common ones that we see are recall, information processing speed is decreased, trouble with attention. So many of these patients will end up having evidence of attention deficit disorder, and then executive dysfunction. They can also have mental health and behavioral problems such as irritability, emotional lability, fatigue, sleep disturbance, eye movement problems. One of the more common ones I see are convergence insufficiency. They usually don't notice it. The way we pick up on that is because they have trouble with reading. And as you know, when you try to read something, your eyes have to converge in order to do that. And they end up not being interested in reading. Or more commonly, because a lot of people now have cell phones, smartphones, you're trying to read the text message or do your social media, it becomes cumbersome because your eyes have to come close together when you're trying to look down at that screen to read something. And it can get impaired physical function. The cost of this per year in the United States is about $40 billion. Lots of services are needed. And this is where a lot of the disparities are going to be coming into play. We have disparities in terms of prevention, which I'll talk about later, but we have a lot of disparities with regards to access to much needed services. And one of the things we found is that language, meaning not speaking English particularly, as well as insurance status, serve as major obstacles to people getting the help that they need. And you can see here a large range of things that people will need after they have traumatic brain injury. Physical therapy, especially many of my patients will require vestibular therapy because they develop vertigo. Occupational therapy with a focus on vision therapy for many of those patients. Speech and cognitive therapy, neuropsych testing. Some of them will go for acupuncture. I'm a big proponent of other forms of therapy like art, music, animals. So people, you might see them, with a, dog, cat, or other types of animals to provide a lot of times emotional support. Movement therapy, such as dance, as well as game therapy. So these are all things that we want to encourage these patients to get. But again, oftentimes people have difficulty accessing these services. Other ones we need: neurologists, rehab medicine, social workers, audiologists, neuroimaging. So now one of the big challenges, you heard me speak earlier and describe that a large portion of the people with traumatic brain injury are from motor vehicle accidents and accidents in general, right? These are people usually having an accident. And when you have an accident, you end up, usually what ends up happening is your regular health insurance, will often not cover the services needed for your care. And so these patients end up needing care from providers who take workman's compensation. Huge disparity because many providers prefer not to take this insurance because they don't want to, some of them don't want to fill the paperwork out. They feel like it's too much hassle to get reimbursed for the care that they're providing. If you want to prescribe a particular therapy for those patients, it has to go through multiple levels of approval from the insurance companies. So a lot of doctors and other providers find taking care of patients who require workman's compensation or other no-fault types of insurance less satisfying because they're not able to provide the interventions that these patients actually need. And so one of the pieces of legislation that there's a lot of interest in is making it so that there's a lot less red tape, so that when the doctor orders a test or orders a medication or orders some form of therapy or recommends a therapy for a patient who has suffered these traumatic brain injuries or other injuries, that they get approved on a much more rapid basis. I have patients where 6 months go by and I'm still asking for approval for something that the first time I saw them. This is a delay in treatment, a delay in management, and overall a worse outcome for those patients. Now, what ends up happening is patients who are more affluent, who have more money, and will end up being able to pay for some of those things on their own. They'll pay out of pocket to get those types of services, whereas those with less means end up suffering a much longer period of time with this ailment because of the difficulty with getting the insurance approvals. So other disparities in traumatic brain injury. Yes, there are disparities seen with racial and ethnic minorities. Obviously, from just understanding of structural factors, we know a lot of times these racial ethnic minorities tend to often, because of redlining and other societal issues, have ended up in the lower socioeconomic status. So when they have those injuries, they might be more reliant on the workman's compensation or no fault to pay for services that are being delayed and being offered. People in corrections and detention facilities. Again, we know because of the criminal justice system, Black, Latinx individuals tend to be more likely to receive punitive punishments for certain things that they do, which means now if they're in the correctional facility and they have traumatic brain injury, again, there's going to be a treatment gap there. They might not get access to the appropriate medical providers, and they might not get the treatments that they need in order to address their traumatic brain injuries. We talked about a bit already, low income and underinsured people. And then the final one will be people who are living in rural areas. We know there's a great deal of issues with providing care. You heard it from our prior speaker that these are huge gaps in care in these patients. Legislation over the years to have tried to even the playing field. The TBI Act of 1996 developed uniform reporting system for traumatic brain injuries, and really also encouraged more research in this area. And then in 2008, that same act was reauthorized to bolster the research and really looking at some of the preventive measures to avoid people having traumatic brain injury. Title 13 of the Children's Health Act of 2000 provided for protection and advocacy for individuals with TBI and their families. And one of the big breakthroughs really I'd say in the late 2000s, 2009, 2010 period of time, new return to play guidelines. I can tell you when I was a neurology resident, we did not spend a great deal of time learning about return to play. People, athletes who suffer brain injuries, we would get, usually one token question on our in-service exam that we never really learned from anybody. You just say, oh yeah, I think I know that answer because you learned it from a prior practice exam. But now this is being pushed a great deal more. One of the things we know about health disparities is that the more standardized, the more standardization that we have in our processes, the more likely that everyone is going to get the same or better quality care. When there are no guidelines, you end up being subject to a lot of subjectivity. And so with the subjectivity allows for implicit bias and other forms of bias to be able to set in. But having these return to play guidelines, having guidelines in your medical records, all those guidelines have a tendency to help decrease those disparities. I'm going to share just a little bit of data about some disparities. So we know that patients who sustain, this probably looks just kind of similar to a slide you saw earlier. Patients who sustain TBI in rural areas of the United States do have a higher fatality rate. And you can see here that the more rural states are in darker red, which indicates higher fatality. And then here, this is another slide. What you see here is that the patients who sustain TBI in the rural or predominantly low resource environments have a significantly higher risk of death than those in urban regions, the high resource environments. In this study, the disparity in outcomes from TBI for patients in rural versus urban environments is demonstrated, and the all-cause mortality from TBI is actually 23% higher in the rural areas relative to the urban areas in the United States. Because of these disparities, Joe Biden has proposed, I think they're actually in the process of actually getting this, it might have already be in place, a rural health czar. The idea of this person would use case management models, transition of care models, family-centered care models, do everything it takes to improve the care of people who are in the rural health. And that includes the telemedicine services, which can be used to provide remote care to these patients. We've talked a little bit about this before. Telemedicine, this is something that there's been a great deal of interest in it. We've had the capability to do it. However, insurance companies were not approving us to be able to do this type of treatments. and to bill for it. In March of 2020, with the COVID-19 pandemic, amazingly, the Congress passed legislation authorizing payment for physicians who are seeing patients through telemedicine. And I can tell you, before they even passed that legislation, our office started doing it. We said we don't care if we don't get paid, because we want to be able to provide the care to our patients, and we want to do it in a safe way, so we're not putting our patients at risk. As you know, in neurology, our patients are disproportionately older patients, so to avoid putting them at risk, we converted to telemedicine, and really within about 2 or 3 days after we did it, the legislation got passed in Congress. And so now removing that barrier makes a big, huge difference in patients. I'm not sure if some data by some different researchers who have published data on TBI. This is a study looking at outpatient rehab services for children who have suffered traumatic brain injury. And one of the main things they found is there's trouble getting services in your own language. So, and then also many providers do not accept Medicaid insurance. And what we see is that Medicaid and requiring a language interpretation was most disadvantaged. So obviously we need policies to be in place to incentivize providers to provide care to these patients. Insurance not being accepted is a huge barrier to care for providing mental health, PT, OT, speech language pathology, and all the services that I spoke about earlier. This is another study by the same group. Got an ant on my computer. What they found is there's no difference in mental health services during the hospital admission. However, the disparities happen after the hospital discharge. 3 months and 12 months out, you can see that the disparity is actually getting wider and wider for Black and Hispanic patients. I share this with you. This is an important, really nice model that I like to share about, called the COIN model, which goes over privilege and allyship. And this COIN model basically says here that this coin represents the system of inequality that's in place. And people could be on top of the coin and have privilege, and they could be in the oppressed group, which do not have privilege. And they could put lots of different groups on top versus on the bottom. In this case, you would put rural medicine would be on the bottom, urban would be on the top. One of the ways to think about this, I like to think about a coin. Instead of thinking of a coin as having a top and a bottom, either you can dismantle that coin, so that it doesn't exist, get rid of the disparity, or maybe the coin shouldn't be a top and bottom, should be 2 sides to every coin, a left side and a right side, so that nobody's on top. And that's why by having appropriate legislation in place, you can actually be able to try to level that playing field, so that there is no longer a top and a bottom for all these different things. So how legislation has been able to help prevent the health disparities, mandating particular safety measures and guidelines for baby car seats. Say you cannot drive your car unless the baby car seat meets these particular specifications. That's going to lead to great improvements in preventing brain injury and other types of injuries. Booster car seats, emphasizing this in certain communities. Information in different languages, gun laws, return to play guidelines that I spoke about earlier, concussion education for both school administrators, the coaches, everybody who's involved, all stakeholders need to understand these areas. Highway safety measures, education, telehealth for the rural communities has been very helpful. And also for other communities in neurology, think about our patients who have epilepsy, who have other types of neurological conditions that make it so that they cannot drive to a doctor's appointment and they're reliant on rides. So having that telemedicine really does make a big difference. Okay, seatbelt usage, huge difference here. Everybody should be wearing their seatbelts when they're driving in a car. Here you see the numbers here. The rates of seatbelt usage was 14% in 1983, jumped up to 90% in 2016. And that's all because of legislation that's been put in place. Bicycle helmets. In New York State, all bicyclists under the age of 14 years old are required to wear safety certified bicycle helmets when they are operators or passengers in bicycles. Children age 1 to 4 must wear certified bicycle helmets and ride in specifically designed child safety seats. Children under 1 are not allowed to be on a bicycle, so don't do it. Any parent or guardian who permits his or her child to violate the helmet laws is subject to a fine. That fine is pretty modest. And different communities are passing their own more restrictive laws to help prevent these brain injuries. Now, when you put these laws in place, again, education is always going to be important. You don't want to put laws in place and saying, okay, you got to wear a helmet, but the person has no clue how to put the helmet on properly. So this slide is really just to emphasize you have to do it the right way. So follow those safety guidelines. This is just the New York State Medicaid TBI waiver program. I bring this up only because I talked earlier about the fact that people with Medicaid might have less access to care. This is a nice program that's been set up to help people with TBI to be able to live in their community setting of their choice, so that they can actually get services, have a case manager, and really have a chance to have a good outcome. Don't worry about reading the details of this slide. This is a legislation that's been offered up. It's not actually a bill at this moment in New York State, but there is an interest in having more restrictive rules regarding return to play and the sports guidelines for students. Some of the concerns about that is that they want the schools to have certain types of people in place to be able to clear the student for return to play. But when you think about it, when you're requiring not all these children, particularly in low-income areas, certain communities that are predominantly Black and Latinx, don't have access to allow these providers. So if you're putting this legislation in place to make more strict guidelines for return to play, it's also important to provide the funding so that these schools can actually allow their kids to safely return to play and provide the actual service. So if you put a whole bunch of barriers and have no real way for those schools to actually overcome those barriers, that's a big, big problem. So we want to look at that. Last, I'll close with this, which is basically our TBI support group that we have in Rockland County. We have monthly meetings for patients, really all patients. I think it will help overall to eliminate the health disparities because we're regularly educating them. The group is moderated by myself and a brain injury survivor who is also a licensed clinical social worker and therapist. We educate our attendees on resources such as adaptive rowing, music therapy, art therapy, yoga, meditation, healthy diets. And we often have our medical students join in for presenting in those presenting at those meetings. Fortunately, that is my last slide when the gang showed up. That's all I have. Thank you very much for having me.
Thank you so much, Dr. Etienne. And hi, Isaac.
Yeah, Isaac, say hi to Stella. Remember Stella?
Hi. Isaac, look the ears.
Thank you so much, Dr. Etienne and Dr. Lunagariya. So we're open for any questions that anyone might have. You can feel free to shoot in the chat or unmute yourselves. I'm actually just gonna go ahead and start off while other people think of anything else. This is for either speaker actually. Just in terms of like the lack of access to neurologists because of how few of these specialists we actually have. I know in the US, I know Dr. Lunagariya had mentioned that part of the issue is the disproportionately low number of spots in residency programs and fellowship programs for subspecialties. I just wanted to know if either of you know of any programs or movements, like efforts to increase available positions in these programs.
I didn't hear the last part of your question, Stella. Any programs to do what?
Or if there are any efforts or movements to try to increase the available positions in those programs.
Yeah, so interestingly, a few years ago, Congress did pass legislation to increase the number of residency spots nationwide. So not just for neurology, because one of the things you've seen when you look at the residency match each year, is that we're seeing more people go unmatched. And the reason that is because we're gradually getting more students than there are residency positions. So Congress is increasing those numbers. Interestingly, a lot of community hospitals, community programs are now sponsoring residency programs, particularly family practice and other types of programs. But we are seeing numbers. I know my residency, when I was there were 8 residents in it. Now I believe there's 12 at that same program. So they are increasing those numbers gradually. And for neurology, it's especially needed because with the aging population, there's a growing shortage of neurologists in the United States.
Dr. Lunagariya, I think you're muted.
Yeah, so to add to that, like, yeah, Medicare is increasing the number of sport. At the same time, like, it's all about the leverage, and there is also like disproportionate need even in primary care. We have to accept the fact, and that's why, like, if there is an increase, most of that might or would go to primary care. And we are at slightly disadvantaged position because neurology is still not considered primary care at most of the state legislative places. They consider family practice, internal medicine, OBGYN, pediatrics and psychiatry as a primary care. Neurology is still like not considered there, but like hopefully with all the processes we might get there, and with more volume we might get more leverage. So it's just like chicken or the egg situation.
Yeah, excellent point. And we are, neurologists, we end up being very much like a primary care specialty because a lot of our patients with chronic neurological conditions, a lot of them really just dump, I mean literally dump their primary care and don't go back and say, well, my problem is this, and why would I go back to that person? So we end up having to do a lot of this, a lot of these management. So hopefully in time we will get that designation, which will make a big difference.
Thank you. So I guess that goes into, advocating during those AN conferences and all that as well. Awesome. Does anybody else have anything that they want to ask either of the speakers?
So I know we keep bringing up this shortage of neurologists, and there's a shortage of, or there's not enough residency positions. Does that extend into fellowship positions?
So that's a good question. So like, they say that in neurology, getting fellowship is a little bit easier than getting a residency. Difficult part is to get a good fellowship. So what ends up happening, like I'll just like say out where I did my residency, University of Florida. When I was in my class, we used to have 4 residents. Now there are 8, and they're even expanding it now further. And when we were 4 resident, at that time we used to have like 2 fellowship for stroke, 2 fellowship for movement disorder, or 2 per year, so 4. 1 for neuromuscular. So we were having like maybe like around 8 to 9 fellowship when we were having 4 residency sport. And that might be true across the country, and like we have more fellowship sport, but at the same time keep in mind that we can only have as many as fellow as like we have resident. We can't have more fellows than the resident because you have to have neurology training before you even pursue fellowship, and that's where like the bottleneck ends up happening. Then again, one more thing. I mean, I'm right now in a relatively new program in Orlando, Florida. Our first batch is graduating this summer. So the problem to get SCGME approval for like a lot of new programs, that you need to have like sizable number of full-time faculty in any hospital. And for community hospitals or like mid-sized hospitals, you might have far more faculties for medicine than neurology, which are full-time there. And that's gonna persist for like foreseeable future. In other words, guy, future for neurology is bright. You will be always in demand, at least for a couple of years to come.
That's very reassuring. Thank you.
I had a quick question for Dr. Etienne. When you were talking about disparities within traumatic brain injuries, I was curious if you had any resources on this question specifically. So a couple of us were currently just interested in understanding disparities in diagnosis and treatment of TBIs. Do you happen to have any information or any knowledge on if one's race, sex, or socioeconomic status influences their diagnosis of either getting diagnosed with the TBI as opposed to like a psychiatric disorder. This kind of came up as a conversational idea, but I'd love to hear from someone who has practical experience in the field.
So the thing about TBI is that one of the real big challenges is that because the training has been suboptimal. So one of the things about disparities in general, health inequities, is the less training people have in a particular area, the more room there's going to be for health inequities and health disparities. Okay, so the better you're trained in it, the better you're going to be at being able to pick up on certain diagnoses. Now, when it comes to traumatic brain injury, one of the big problems is that, you know, patients across the board are discounted about having traumatic brain injury. You know, people, you know, because especially since the majority of them are called concussions, and concussion by definition is a mild traumatic brain injury. And so everybody says, oh, because of that word mild, people have trouble understanding why 3 years after that mild traumatic brain injury, the person still can't go back to work. And that's happening to really all races. And I'm not sure if it disproportionately happens to one race versus the other, but just by virtue of minority patients being at higher risk for it, just based on the things that they're engaged in, just occupational and those types of things, you would think that it's going to end up happening more to them disproportionately. I don't have the actual figures to cite that, but that's the main thing I would just say with that. But sadly, it's one of those areas where really everyone is universally underdiagnosed with their brain injuries, to the point that usually their families don't believe them, their workplaces don't believe them, the doctors don't believe them. The majority of my patients with TBI, I'm usually giving the second or third opinion because their prior neurologist told them that they're fine, and they're not. And they find me on the internet because they're like, okay, this guy, like, either he just believes everything or he just believes in us. And that's one of the things. And when you think about implicit bias, people are more likely a lot of times in the racially discordant physician-patient relationships, you're less likely to believe, particularly if you're looking at a white physician, less likely to believe a minority or Black, Latinx, Asian patient. So that's really the source of a lot of that.
Thanks for that. Yeah, I definitely agree with you there. As a medical student, sitting in
who's speaking, by the way? I can't see who's speaking. I just see DV.
Oh, sorry. Can you see me now?
Okay.
Yeah.
I got you. Okay.
I'm Daimler. I'm one of the medical students at the University of Queensland-Ochsner. I actually work with Phil and Stella as well as part of NeuroEquity. So it was great to hear you speak.
Great.
On that point about bias, I had a chance to work with one of our sports neurologists who hosts a TBI clinic, and I had the chance to see some of these patients come in, with these longstanding complaints, and it really took me a second because, I almost didn't believe them, and it took, a conversation for it to happen for me to fully understand the longstanding effects of this, so I can completely understand how this is a big issue throughout the country.
Yeah, I have a guy, for example, suffering for years after traumatic brain injury, and whenever he tries to read, he starts crying, and everybody, he was called psychiatric. He's just emotionally labile. He was discounted, and I saw him, and in my examination, I saw that he had a prominent convergence insufficiency, burst out into tears during the examination, and I said, you've got a pseudobulbar palsy with a pseudobulbar affect. Place them on the appropriate medication. We have medication to treat that. And within a few weeks, he's like, oh my God, I'm a new person. I've got my life back. When for all these years, I've been told I was, crazy, this, that, faking, all these things. And, it's like, why would I be faking this thing? And you can treat these people so they get discounted. And a lot of it, like I said, it has to do with training. The less training you have, the less well-trained you are, the more we see these health disparities. Institutions that pride themselves on high quality care, that high bar, everyone ends up benefiting because you end up bringing everybody up. So even though there might still be a little bit of a health disparity, it's not going to be as pronounced as the place where you've got poor care, poorly trained people who don't know, they're discounting everyone, and they don't have, clear protocols that they follow. So protocols, guidelines make a huge difference in terms of eliminating and limiting these health disparities.
Thank you.
I think to add to that, like there is one mentality in medicine to begin with, not just neurology. We don't believe what we don't see. And unfortunately for TBI, like you do not see much changes in the MRI brain or like CT scan or those things. There is no objective measure for those things. It's not like that, okay, you have myocardial infarction, you have ST elevation in EKG. We don't still have that many biomarkers, and that's why we do not sometimes believe what we don't see. And on top of that, if you're not trained enough, or if you have like 20 other patients to take care of, then maybe you would just start like, stereotyping patients, and it will very easily like fall to that route.
Yeah, the person looks fine. You look great. You say, oh my God, you look better than I do. The TBI patient, he's like, well, you look well rested, you look good. You're fine. And it's like, no, they've got so much going on. Can't read, can't do this, can't do that.
All right. Well, thank you guys for that. So I just have one more question. Obviously, we want to be respectful of everyone's time here. So we're going to answer one more question from the chat here, if you speakers have a second, and then we will adjourn for the night. So Danielle from our chat here says, are expanding telehealth and residency positions the only ways to expanding expanding access to neurological care, or are there any other solutions being considered?
So you want me to, so expanding access to neurological care. So aside from telehealth, the other thing that you want to do is ideally you want to try to train people who are likely to go back and work in the communities that are facing those disparities. So we know already that Black, Latinx medical students, physical therapists, whoever, whatever those services are more likely to go back to their communities. So you train them, you're more likely to get people into those, to go back to those communities. We're talking about rural medicine. Montana, is there a medical school in Montana? I don't think so. So we want to try to get, you want to help Montana and improve their health in that area. Telehealth is one thing, but what about trying to put some doctors, nurses, and everybody else into those communities? So that they can actually be able to take care of themselves to some degree and not be 100% reliant on people from other states. Montanans, I'm saying Montana just as an example, really care about Montanans, right? North Dakotans, South Dakotans. So they're from the community. They probably understand their community a lot better than I would if I was doing a telehealth for them. So having those people, boots on the ground who know that community and can offer the various services that are needed really makes a big difference. So I think trying to train, that's why you see medical schools and whatever schools are out there say, we have people from this state, that state, this state. It's not just bragging rights about number of states. We're going to be able to train these people to actually potentially go back to their communities and provide a very needed service to help eliminate these health disparities. You can't, the telemedicine is great, but you're basically making them dependent on this outside service.
So like, because there is a lot to add to that, because there is a shortage of good quality doctors and like shortage of doctors to begin with, there are some opportunistic bodies out there who are trying to like put themselves similar to doctors. and say they're equivalent to doctors, and patients sometimes doesn't know the difference, unfortunately, because if someone tells them I'm a doctor, they don't ask whether are you DNP or are you MD. We should not go to that route, because like at the end of the day, goal is to have a quality care for patient. I mean, not just any care for the patient. Second thing I would add is that like a lot of times, if you look around, there will be a lot of doctors around you, either medical students or residents or clinician. They might be from different countries, and they might have a barrier to living and practicing in United States purely because of immigration regulations. So it happens that our institutions are training them, they're teaching them, they're making them capable, but once they're capable, they have to go back, or they're almost like asked to go back to their home countries and practice. So we are losing a lot of those things, and there are a couple of regulations in pipeline. Hopefully they will be passed soon, but these two things, I think they are very important, because there is a gap doesn't mean that anyone can fill the gap. I mean, someone has to be trained enough for that.
Yeah, absolutely. I'm glad you brought up the word pipeline, because pipeline programs make a huge difference, and that's what we really have to do, is look at starting. We got to plan for the future now, and look at 6, 7, 8-year-olds, get them interested in neurology, get them excited about the brain. So many people, I don't know where they get this idea about the heart. Like, oh, the heart is just so cool. It is. I like the heart. It's nice. I like what it does for the brain, but show these kids the brain. They're going to see how cool that thing is. This is who you are. This is what makes you do all these things. So, AAN has some great programs to try to get